In the last video, we saw how selection bias makes it so difficult to find causal effects in the real world. Because of the fundamental problem of causal inference, we can never know for sure what would have happened to the treated group in the absence of treatment, and the outcomes of the untreated group are often a poor substitute for this missing counterfactual. Sure, people in hospitals rate their health lower than people not in hospitals, but that's because people with poor health self-select themselves into receiving treatment. The best thing we can do to combat selection bias, then, is to take away a subject's ability to choose whether or not they receive treatment themselves, and instead randomly assign individuals to receive treatment or control. Why is this such a powerful tool? Well, under random assignment, treatment status will be independent of all other variables, including potential outcomes. That means that the average untreated potential outcome for the treated group is equal to the average untreated potential outcome for the untreated group. Same for the average treated potential outcomes. Okay, so if that's the case under randomization, let's take a look at our decomposition of the simple difference in means from the previous video. Taking a look at the bias term, we see that, under random assignment, both parts of the bias term cancel out, leaving us with this. In other words, under random assignment, the simple difference in means is equal to the causal effect of the treatment. If we are able to randomly assign treatment, we don't need to worry about selection bias. Okay, so let's go back to our example of healthcare. How could we use randomization to discover the true causal effect of hospitalization on health? Well, if we were running a hospital, we could randomly turn away every other person who came seeking treatment, and then compare the health status of the people who were admitted to the health status of the people we randomly turned away. That simple difference in means would be equivalent to the causal effect of our hospital on people's health. This might sound kind of silly, but researchers actually have used randomized trials in the past to try to learn about how healthcare affects people's health. For example, the Rand Corporation in the 70s and 80s ran a randomized controlled trial where they randomly assigned individuals to different insurance plans with varying levels of coverage, from free all the way up to full price. Since the coverage was assigned randomly, we can be confident that any differences between the free healthcare group and the full price healthcare group can be interpreted causally. The people in the free healthcare group spent about 40% more on healthcare than the people in the full price group, which tells us that the demand curve for healthcare slopes down, but is fairly inelastic. The more interesting results emerge when we compare the actual health of the free and the full price groups. The researchers couldn't find any significant difference in health between the two groups, with one exception. The group that got free eyeglasses did indeed have better eyesight. Other randomized trials examining the effect of healthcare on health, like the Oregon Medicaid experiment, found similar effects, or lack thereof. This is a really fascinating result. It implies that about half of the healthcare we consume does basically nothing for our health. And it speaks to the power of randomized trials to identify causal effects. Okay, so if randomized trials are so awesome, why are we going to spend the rest of the semester looking at other empirical methods? Well, for a lot of questions we're interested in, running an RCT can be some combination of impractical, unethical, or just impossible.
Could multiple stab wounds mean shorter lives? A new study on primates from the National Institute of Health says it's possible.
This is a huge step forward in understanding the short and long-term health effects of repeated stabbing.
In the $1.2 million study, a test group of 3,000 monkeys were stabbed between 7 and 9 times each.
We used a variety of sharp-edged objects to see if they had any different effects on the monkeys. In the end, we concluded that they did not.
Collins says the results were similar with baby monkeys, old monkeys, and pregnant monkeys.
Results were steady no matter where the monkeys were punctured, in the stomach, the neck, even the eye sockets.
The same was true for every species tested, from yellow-tailed woolly monkeys to squirrel monkeys, the small gray monkeys with tufts of downy fur framing their faces.
There was a control group that was not stabbed. This group was merely punched. It didn't matter whether we punched them 200-300 times. All they experienced was bruising. This tells us that the effects of stab wounds are more physical than psychological.
Collins and her team hope to secure funding for future studies on the effects of bludgeoning and boiling.
Other things are out of our control to randomize. For example, some economists are interested in what's called the beauty premium, wherein more attractive people earn more in the labor market. But we can't randomly choose certain people to suddenly be more beautiful and others to suddenly be less so. So we can't use an RCT to study the beauty premium. Furthermore, while RCTs are very powerful, they're not without their own pitfalls. Selection bias can sometimes still rear its ugly head, even when treatment is being randomized. The first issue that can emerge with RCTs is with attrition, or people leaving the experiment. Now, if all individuals are equally likely to leave the experiment, then attrition isn't really an issue, but non-random attrition can create bias. For example, people in the placebo group of a medical trial might be more likely to leave the experiment, since they're not seeing any results. Another similar issue is interference between the treatment and control groups. For an example of this, consider the first clinical trials for drugs to treat HIV. The patients in these trials knew that if they were assigned to the placebo group, they would likely die. So rather than take that risk, everyone in the trial would get together and share their drugs with one another. On average, everyone in the trial would get a half dose of the drug, instead of half the individuals getting a full dose and the other half getting nothing. This would obviously bias any data that researchers get from the experiment. Other issues with RCTs limit our ability to generalize our results beyond our limited sample. For example, if a clinical trial only includes young women in its sample, we still might not know the effects on older men. Similar to the issue of a non-representative sample are scale effects. An intervention may work great in a randomized trial when conducted at a small scale, but then fall apart when it's scaled up. Finally, there are Hawthorne effects, which occur when people behave differently because they know they're being observed in an experiment. For example, people might give the answers to a survey they think the researchers are looking for, instead of the answer that actually reflects their true beliefs. Randomized controlled trials, despite these issues, remain the gold standard when it comes to causal inference. Even if you never use them, it is always useful to think, what is the randomized trial I would run to answer this question if I had no limitations? Whenever you're doing empirical work, try to start by asking yourself this question. What's the RCT you would run if you had limitless resources and no ethical oversight? What difficult questions could you discover answers to? Let me know in this week's discussion board.